Hello and welcome everybody to today's session. I'm Melissa Mello. I am the coordinator here in the Rady Faculty of Health Science Family Center. The Family Center is a resource here to support learners, faculty, and staff who have family responsibilities while also studying or working in the Rady Faculty. We aim to assist those as they navigate major life changes and the challenges of caregiving. And our goals are to determine and address the current family-related barriers affecting our diverse community and to create a more family-friendly campus here at Bannatyne. Today's session is called Cognitive Decline in Aging, Answers to Frequently Asked Questions. And our speaker today is Dr. Colleen Millikin, and she is a clinical neuropsychologist with the Clinical Health Psychology program working at the St. Boniface Hospital in the Health Science Center. She specializes in assessment of older adults with suspected cognitive disorders. She is also an assistant professor in the Department of Clinical Health Psychology in the Max Rady College of Medicine, Rady Faculty of Health Science at the University of Manitoba. In this session, Dr. Millikin outlines the differences between normal and expected cognitive changes in aging, mild cognitive impairment and dementia, and other topics will include factors that may increase or decrease risks of cognitive decline and what steps to take if you have concerns about memory changes in yourself or someone else. And just before I hand over the session, I would like to do the land acknowledgement. The University of Manitoba campuses are located on the original lands of the Anishinaabe, Cree, Oji, Cree, Dakota, and Dene people, and on the homeland of the Métis Nation. We respect the treaties that were made on these territories. We acknowledge the harms of the past, and we dedicate ourselves to move forward in a partnership with Indigenous communities in a spirit of reconciliation and collaboration. And I also wanted to let everybody know that this session is being recorded. And at the end of the session, there will be a short question period. So feel free to write your questions in the chat box or raise your hand at the end of the session, and Dr. Millikin will get to your questions at that time. And so without further ado, here is our speaker, Dr. Millikin.
Okay, thank you. I hope everybody can hear me okay. So I am going to just do a really quick overview, and I wanted to thank Melissa for the introduction. So here is a quick overview. I am kind of covering a lot, but my plan is to leave at least a few minutes for questions. So the first thing I wanted to talk about is what changes in memory are normal or expected with healthy brain aging. So I've had somebody say, well, I don't like this term normal. So I'm trying to use expected, but basically normal is in terms of kind of what we would expect and normal for the person. And then I'm going to talk about what is mild cognitive impairment, because that's a less commonly known kind of a term. What is dementia, which I think probably a lot of folks are familiar with. What should I do if I'm worried about my memory or other person's memory? What treatments are available? And what are some risk factors for developing dementia? What are some lifestyle habits that may reduce risk? And other frequently asked questions, which I'll hopefully get to. So in terms of memory is the biggest thing that people think of when they think about memory changes in aging. So with healthy brain aging, there's a slight decrease in processing speed, and this is a natural consequence of aging. So just as people who are kind of over 20 can't run as fast as 20-somethings, that's just kind of the way things work. And this may be responsible for some of the changes in memory and attention that happen. Sorry, I'm just going to see if I can minimize everybody else so I can see my whole slide. There we go. So in terms of healthy aging, information does get stored, but there can be difficulty retrieving. So that little file clerk in the brain may have difficulty finding those pieces of information when you want them. And oftentimes the information comes back later, and cues and hints can help. Whereas memory in dementia, new information is lost quickly, so people may pay attention to the information, they can say it back right away, but 20 minutes later that information is not there, it just didn't stay in storage. And cues don't help as much because the information has been forgotten. And people often don't remember that they don't remember. And so this leads to the situation where family members are much more aware of the problems. And the person who has dementia may say, oh, I think my memory's fine, or I'm getting a little older, but it's not that bad. And that's because they don't have a kind of a record of the difficulties that they've had. So this is just kind of a little cartoon showing rapid forgetting, where the information just kind of gets erased. I sometimes use the term, it's kind of like writing on a whiteboard in a rainstorm, that you can't get that information to stick. So language is another area. I'm not going to talk about all the different cognitive domains that I assess when I'm doing an assessment, but in terms of language, very many people who come to see me complain about word finding difficulty. And that's often difficulty retrieving words in conversation, especially nouns. And this happens very commonly in healthy aging. It can happen sort of increased with menopause, increased with stress. And this is thought to be due to slowed processing speed. So you can get that information out, but it's not going to come when you want it, because you're kind of putting pressure on your brain to give you information quickly. And there does tend to be more difficulty with word finding in mild cognitive impairment, relatively. And then in dementia, there are more frequent errors. So someone might say weeks when they mean months, or nephew when they mean grandson, that kind of thing. And there can also be, as dementia progresses, difficulty with comprehension of language. And that can lead to difficulty, both memory problems and language problems can lead to difficulty with behavior, where if people aren't understanding what's said to them, they may respond in ways that aren't expected and that are potentially challenging for people around them. And there are some types of dementia that primarily affect language. We call them progressive aphasia, but they're pretty uncommon. So I look at both how people do in terms of their memory function or other cognitive functions compared to people of similar age, but I also look at how people are doing in their everyday life. So when I am seeing somebody who has kind of a healthy brain, relatively healthy brain, then their cognitive abilities on my assessments are normal or where we would expect for their age and their background, and they don't have any change in their activities of daily living. Mild cognitive impairment is where there's a measurable decline in memory or other abilities compared to people of a similar age. So when I compare a 75-year-old to people between 70 and 80, they're not doing as well on some of these tests. So, but they're still independent in activities of daily living. And then in dementia, there's a measurable decline in memory and other abilities often. So things like language, visual ability, executive functioning, and there's a clear decline in activities of daily living. So I actually usually share this type of a slide with people. So it's fairly easy to distinguish between healthy aging and difficulties that are more than we would expect for aging on our testing, because we have normative data. We know kind of how the average person of a certain age or with a certain level of education would be expected to do. So if there's a significant change from that, where the person's scores are well below where we would expect, then we can say, okay, maybe this is mild cognitive impairment, or maybe it's mild dementia. And if we're talking about moderate to severe dementia, I usually don't see those folks because they're having other kinds of issues and there's less of an issue with differential diagnosis. So my type of assessment is less useful when there's very obvious dementia. So everyday functioning, if somebody has kind of healthy or expected aging, there's no change. They're still able to do things like cooking and managing finances as well as they ever did. So sometimes people may have had challenges with different activities, but there's no further decline from their previous level. Mild cognitive impairment is where there's no change or very mild change in ability. And then mild dementia is where there's more significant change or decline in their abilities in everyday functioning. And so I have a little dash line in there because there is no kind of hard and fast demarcation between those. It's a very kind of qualitative, and it really revolves around my kind of clinical judgment or other people's clinical judgment of where people are at. So I've had people referred for mild cognitive impairment, and I say, well, based on my assessment with the information that I'm looking at, it does seem like more that it's mild dementia. And so sometimes I'll say, well, it's not like diabetes, where diabetes, if your blood sugar is in this range, it's normal. And if it's in this range, then you have diabetes. It's not nearly that kind of quantitative, it's more qualitative. So these are the kind of activities of daily living that I look at. So instrumental ADLs are more complex kind of tasks like driving, banking, cooking, managing finances, keeping track of appointments. And those are usually not affected in mild cognitive impairment. And again, I'm looking at a qualitative change from the person's previous level of ability. So if somebody was an accountant and now they're having trouble doing their own taxes, or they were a gourmet chef and now they're struggling with simple recipes, then there would be clearly a change or decline from their previous ability. Whereas, for example, I've never had a good sense of direction. So if I go to somewhere that I'm not familiar with, I have to add in an extra 10, 15 minutes to get turned around and have to pull over and look at a map or whatever. So that wouldn't be a change for me. And now there are generally declines in some of these IADLs in the mild dementia stage. And often it's more than one. So if somebody is, for example, missing a couple of bill payments, not a big issue unless maybe they're also losing track of their medication or getting lost while driving. So usually there's multiple kinds of difficulties people are having if they have mild dementia. In moderate to severe dementia, that's where you start seeing change in basic ADLs. And those are things like dressing, bathing, grooming. And I'm not going to talk much about behavior in dementia because that's a whole other topic. And I could talk about that for over an hour fairly easily. But these are, when I'm trying to decide between, is this mild cognitive impairment or is it dementia? These are the kinds of things that I look at. And oftentimes the information is coming from a family member because sometimes people aren't as aware that they're having difficulty. So what is mild cognitive impairment? I'm guessing a fair number of you have heard that term, but it's certainly not widely known in the general public. So it's this kind of in-between condition where people's brain function is not normal, but they don't have dementia either. And dementia, by definition, is a change in functioning in everyday life. So people with mild cognitive impairment are at higher risk of developing dementia over time, but not everybody with MCI goes on to develop dementia. And some people actually improve a little bit, but even folks who improve get back to sort of normal expected level of test performance, they still will have a higher rate of dementia progression over time. And depending on the study, whether it's a clinic study or a general population study, between 6 and 15% of a sample of people with MCI will develop dementia each year. So if it's a sample where the progression rate is 15%, by about 3 years on, or 3-4 years on, close to half or more than half of that sample of people will have dementia, a diagnosis of dementia. And we, my colleague and I, Dr. Leslie Coven, set up the Early Cognitive Change Clinic for older adults to try to identify people with mild cognitive impairment, because if we're not seeing people until they have dementia, sometimes people are at a point in terms of their progression of brain change that they can't make a will or they can't assign power of attorney. So those sorts of, that window of opportunity might have been missed. And there is some evidence that changing lifestyle can be a benefit for preventing progression or slowing down progression. And currently, we don't have any evidence that medications that are approved for Alzheimer's disease, that those help in mild cognitive impairment. And there's actually evidence that people with MCI have a higher risk of side effects. So at some point, we are hoping that hopefully in the near future, that there will be some medications that are approved for MCI and that show benefit, but we aren't there yet. So dementia, as I said, is a brain disease that produces widespread deterioration of mental functions. And so the term I use sometimes is a neurodegenerative disease. And it often, the Dementia Syndrome, which is the changes in function, that often includes memory, but not always. And I use the analogy to autoimmune diseases. So under the umbrella of autoimmune disease, you have rheumatoid arthritis, lupus, multiple sclerosis, ulcerative colitis, lichen planus, a whole range of things, but they all involve a similar kind of a pathology, similar dysfunction in the body. So this is just a graphic showing the dementia umbrella with the different types of dementia underneath that. And so people say, well, you know, they told me it was dementia, but they didn't tell me it was Alzheimer's disease. And so there's a lot of kind of misconceptions around how does dementia relate to Alzheimer's disease. And so dementia can involve a whole lot of different types of subtypes. But if the diagnosis is Alzheimer's disease, then the person does have dementia. But not all people with dementia have Alzheimer's disease. So they're it's kind of like, sometimes I'll say, you know, a Ford is a car, but not all cars are Fords. So that kind of idea. And Alzheimer's disease is the most common subtype. But vascular and mixed dementia are also pretty common. And especially as people get into the mid-80s and beyond, when people have dementia, oftentimes it is a mixed kind of underlying pathology. And there are some other subtypes like dementia with Lewy bodies, Parkinson's disease dementia, frontotemporal dementia, and frontotemporal dementia in particular is one that tends to show up at an earlier age. So if I'm seeing somebody in their 50s or 60s, I might have frontotemporal dementia higher up on my differential. So the types of patterns of progression, and again, I'm talking about what does the dementia syndrome look like as there's progression. So clinically, what types of functions are affected and how do they get worse over time. So vascular dementia may be a stepwise progression where there's sort of periods of stable functioning and then decline over a few days or weeks. And that's because of changes in the blood vessels in the brain. Sometimes it's a gradual change, so it's very hard to predict. And the cognitive abilities affected depend on the location of the strokes, if there's multiple strokes. And often there's slow processing speed, and that's because the white matter in the brain is affected. And the white matter is kind of like the insulation of the nerve cells. And just like with electrical cables, if you have holes in the insulation on your electrical cord, it's not going to flow as well if there's going to be a problem. So Alzheimer's disease, the progression is usually slow and gradual, usually starts with memory, affects language, visual spatial ability, planning and judgment, and other cognitive functions. So over time, there's kind of involvement of a lot of brain systems, but it typically starts with memory. So this is an example of a brain scan that shows damage to the white matter in the brain. And these are brain kind of tracts that connect up the subcortical parts of the brain with the cortex. And so that's really why there's slowing, because the information isn't traveling the way it's supposed to. And so I'm going to come back to about vascular risk factors, but things like high blood pressure, diabetes, heart arrhythmias, those sorts of things can increase the risk of having this kind of picture. And it can get worse over time. So sometimes the scans will say punctate lesions. So those are little tiny spots. And these would be more what they call confluent lesions, where the patches of white matter damage kind of run together. And sometimes people have a picture like this and their functioning is actually pretty normal. But most often when the radiologist is saying that these are confluent lesions, odds are that there is some impact on daily function. And this is just an example of the progression of Alzheimer's disease. And so Alzheimer's disease is mainly kind of deposition of proteins that kind of gum up the brain and damaged nerve cells. And that typically starts, for still unknown reasons, in the hippocampus or the temporal lobes, so the areas that are really crucial for memory. And then they spread out, or the damage spreads out, and it starts to affect the parietal lobes and the frontal lobes and more of the temporal lobes. And then by the time people are in the severe stage, really the whole large sections of the brain are affected, and people really have lost a lot of their abilities because the brain just isn't working well enough to support the behaviors that people need to have to function independently. So that's kind of an overview of what happens in the brain and what happens at a functional level as there's progression. And I also want to stress that I'm going to talk about age-related change, but the vast majority of people, even at quite elderly ages, do not have dementia. So this is not a normal expected process that happens. So what if I'm worried about my own memory, or I'm worried about a family member's memory or a friend? First stop is the family doctor. So they're really the go-to people. And the first thing that they typically do is do some blood work, rule out thyroid problems, vitamin deficiencies. They look at medications, because some medications can affect memory, and also some over-the-counter medications can affect memory. So if you're taking a medication on a regular basis, it's a good idea to let your doctor know. And the one that's come across in some of the patients that I've seen, pretty small number, but I've come across people who were taking Gravol to help them sleep. And Gravol is one of those medications that interferes, or potentially interferes, with the brain chemical involved in memory. So that's one to talk to the doctor about. And screening tests, I'm going to talk about those in a minute or two. And doing some kind of a brain scan. And most people will get a CT scan. CTs are good for kind of ruling out tumors and things like that, big strokes, or an MRI. And MRIs are relatively more sensitive to that kind of white matter change that I talked about, those cerebrovascular changes. And so from the family doctor, the next step might be geriatric mental health or a geriatric program assessment team, so GPAT. And those are clinical services that provide an in-home assessment of memory, thinking, and mood. So they do the same kind of screening test that the family doctor might do. And the neat thing about geriatric mental health is that you can self-refer, or you can refer a family member. So if you're concerned about somebody, and they also go into the home so they can pick up, are there concerns around safety or nutrition or various things like that. And they also consult with either a geriatrician or a geriatric psychiatrist so they can provide information around medications. So if there is a question of could this be mild cognitive impairment, then my colleague, Dr. Leslie Coben, and I have a service that we run from St. Boniface Hospital that's called the Early Cognitive Change Clinic for older adults. And we need to have a referral from a physician, nurse practitioner, GPAC clinician, and there also has to be, people have to fit a picture of mild cognitive impairment. So if there's significant decline in functioning, then the person probably wouldn't be a good fit for the ACOA clinic, and they have to be age 60 and over. Because under 60, the chances that this is really a neurological type of a condition are fairly slim. It certainly does happen. I've diagnosed quite a few people in their 50s, but if I'm seeing somebody in their 50s, odds are that it's some kind of a non-neurological issue and that they wouldn't meet the criteria for mild cognitive impairment. Excuse me. And so some people need more extensive assessment. So they might get referred to a neurologist, geriatric psychiatrist, or to a clinical neuropsychologist, and that would be me as well. So I have some folks that I will see over at Health Sciences Center. Oftentimes that's people where there's a question of a younger onset dementia or a less common dementia subtype. So those people with that type of a profile might get referred from geriatric psychiatry or neurology. And sometimes they have movement disorders, or there's other kinds of less common types of changes that are suspected. So those are kind of some referral pathways that people may have. And it's possible that if there's a screening measure done at the family doctor's office and everything looks fine, there may or may not be a need to do further assessment. In terms of treatment, currently there's no treatment for mild cognitive impairment. And what I often do when I'm giving feedback is focusing on lifestyle, managing vascular risk factors. So they're really non-specific kinds of things to potentially improve overall health and potentially reduce risk of stroke and risk of cerebrovascular changes. So when there's a diagnosis of dementia, regardless of the type, and there currently are no disease-modifying treatments that will prevent further brain damage or reverse brain damage that's already occurred. And most of the time in this section where I'm talking about treatment, I'm talking about Alzheimer's disease. So there are some medications that are called acetylcholinesterase inhibitors, and they sometimes call them cognitive enhancers. Aricept is the most common one, or donepezil. And what they do is they keep more of a memory chemical called acetylcholine. They slow down the breakdown of that and keep it around in the brain a bit more. And the evidence that we have from clinical trials is that these medications may slow cognitive decline. Some people have a temporary improvement, but it's hard to know whether it's working or not because you don't know what the decline rate would be like if they weren't taking the medication. And some people have side effects, a certain percentage do. So, and most times they're gastrointestinal side effects. So if somebody already has, for example, irritable bowel syndrome, may not be a good fit for them. So I'm not a physician, I'm a psychologist. So what I would do if I'm suspecting that there's an underlying Alzheimer's disease process, then I would talk to the person and encourage them to speak with their doctor about the potential risks and benefits of a trial of Aricept or similar medication. So, and people may have heard of aducanumab, which is a monoclonal antibody. And what it does is it kind of clears some of the amyloid out of the brain. And amyloid is a protein that kind of gets deposited in the brain when people have Alzheimer's disease. Currently, it's only available in the US. It's extremely expensive. I think it's $50,000 a year, something like that. And currently, there's no solid evidence of a clinical benefit. So statistically, they have a large sample of people. They gave half of them aducanumab and half of them some kind of a placebo. And so if you have a large enough sample, you can get very small changes or very small differences that are statistically significant. But I haven't heard any neurologists or geriatric psychiatrists getting excited about aducanumab. It's just not having the clinical benefit that one might want. So other medications, I go to the Canadian Conference on Dementia every 2 years, except we missed the last one, I think, because it was supposed to be in 2021. So with that conference, I try to hear whether there's anything new and exciting. And there's a lot of research going on, thousands and thousands of studies all over the world where there's some human clinical trials, a lot in mice, because you can get mice that are guaranteed to develop Alzheimer's because they're genetically bred that way. And there are some medications that have been found to be effective, and a vaccine that prevents Alzheimer's brain changes, but it's going to take a long time to determine if it's safe and effective for humans. And there is some exciting research going on. One example is that there is a study going on in Toronto where they're looking to see, are there ways of modifying the blood-brain barrier to get medications into the brain that otherwise wouldn't be taken up, otherwise would be blocked by the blood-brain barrier. But it is important to do clinical trials because sometimes things that are promising don't work out. So I'm going to come back to that, I think. So risk factors for developing dementia. Biggest risk factor is age. So less than 1% of people in the 65 to 69 age range are living with dementia. So this is how many people have it. And by over 85, almost 1 in 4. So very, very big changes in prevalence rate and risk. But at the same time, at least 3/4 of people over 85 do not have dementia. So another risk factor for dementia is being female. And there's a lot of research going on about why that is, and trying to see if there are ways of kind of helping people to reduce their risk. Obviously, you can't, if you have a female anatomy and hormone structure, that may predispose to an increased risk of dementia. Again, obviously, not everybody 90 plus, the majority do not have dementia, but it's saying if people have been visiting long-term care facilities, there is a disproportionate number of women in those facilities, and it isn't just because they are living longer than men do. So other risk factors, anything that's a risk factor for stroke is also a risk factor for dementia. And those include things like high blood pressure, diabetes, smoking. And diabetes has also been identified as a risk factor for Alzheimer's disease. Family history, head injury, low education level. I mentioned females at higher risk, poor dental hygiene, and more recently, uncorrected hearing loss has been identified as a risk factor. And I put little asterisks by some of those because they are at least potentially modifiable. So if somebody smokes and they stop smoking, the longer they refrain from smoking, the lower the risk of having a stroke. So in family history, head injury, education level, by the time people are in their 60s, 70s, 80s, there's not as much chance of modifying those things. And head injury in particular, there's still potential to reduce risk of that. But in terms of head injuries earlier in life, people have either had them or they haven't. And it's still really important to look at reducing risk of concussion and risk of other kinds of head injuries earlier in life. So potentially protective factors, these are things that may help keep the functioning of nerve cells as optimal as it can be. So diet is one thing, and there's Mediterranean diet has some evidence of benefit. There's also a similar one called the MIND diet, which also includes some recommendations around managing blood pressure. So high fruits, vegetables, colorful food, legumes, olive oil, unrefined grains, moderate in dairy products, fish, and red wine. And I have that in italics because the MIND diet suggests minimizing dairy products. And low in red meat, saturated fats, and processed food. So there are some other diets that have been advocated, like the ketogenic diet, or there's the Walls protocol that's being tested for multiple sclerosis, but they haven't been tested yet. And it's really a challenging thing to assess a diet by a clinical trial for lots of reasons. Moderate exercise is good for the heart, good for the brain. Sleep. They're learning that deep sleep is a stage of sleep where it's kind of like your brain running the dishwasher cycle. So there's something about being in deep sleep that helps the brain to clear out proteins that might otherwise build up, including amyloid. So that is something that we talk to people about their sleep. We suggest that people get tested for sleep apnea if that's a potential issue, because that's treatable. So some of these are things that are under people's control, are modifiable. And so cognitive activity or mental stimulation means using your brain. And I'll come back to that. Social activity, maintaining social networks, keeping in touch with friends and family. Education, it's good to get a high level of education. And if you're going back to school when you're older, that may not benefit your overall kind of level of brain resilience, but it would count as cognitive activity. So there's still a value in pursuing education or learning when you're older. But the benefit in terms of the development of your brain is really when you're younger. And bilingualism also, when you're younger, if you're bilingual, that's associated with a later onset of dementia. So your brain is more resilient to having some of these brain changes. So you're still able to function and you don't get dementia until later on. And so this is a busy slide and it's not very clear. And I tried to find a less fuzzy one and I wasn't successful. So this shows the process for Alzheimer's disease. And what this indicates is that the brain changes that are responsible for damaging the brain and leading to dysfunction that causes dementia, those start years before the onset of any kind of measurable cognitive difficulty. So this is the amyloid protein that builds up. This is the tau protein that builds up. So it's a later difficulty. And brain structure, so some atrophy starts to happen later. And then it's only, again, years on that you start having some measurable memory difficulty. And so this is the mild cognitive impairment stage where there's definitely some observable memory problems compared to people of a similar age. And then there's a gradual change in clinical function. So that's everyday function. And so that is really the last thing. So if you can sort of slow down these processes, then the onset of mild cognitive impairment and dementia will be delayed. And then most likely people will die of something else, or they will be able to maintain their functioning for longer. So some frequently asked questions. So some people, well, everybody who comes in to see me says, you know, my memory's getting worse. Does this mean I'm developing dementia? And very, very rarely that I have somebody say, you know, I really want to come in to see you because, you know, I think it would be fun to get a memory assessment. People come in and they say, I want to know how long I've got till I have to go into long-term care. They're always very anxious. But a memory problem is not necessarily due to dementia. So anything that interferes with attention can interfere with memory. So you can't get information into memory if something has interfered with the attention process or with encoding. And memory problems are really common in people who have chronic pain, chronic stress, sleep disorders, depression, and anxiety, including anxiety about your memory. So the more anxious you are about your memory, the less well your memory is going to work. And these kinds of things don't tend to occur in isolation. So if you have stress, oftentimes there's depression, anxiety. If you have chronic pain, often there's sleep problems and depression. So these are the kind of what I would call non-neurological factors that can really interfere with memory. And it's not well known and well understood that this can happen. So people say, well, how can my memory be so bad? I say, well, what kind of stress are you under? Did you have problems with memory before you changed jobs and now you're in a really stressful job? So it's complicated, but it's under-recognized that these sorts of factors can impact. So the other thing that I hear a lot is, somebody says that their 80-year-old grandparent developed early onset dementia. And I'm saying, So early onset basically refers to the age that the person was when they started showing symptoms. And that's really vague too, because most people don't start showing symptoms at a particular age. It's a very gradual kind of a change. But if that change starts before age 65, then oftentimes the term early onset or now younger onset is used, whereas late onset is at or after 65, which is a very arbitrary kind of a definition. But early stage means that the disease is still mild and the person is still independent in many of their activities of daily living. And supplements, I get asked about things like Provigil, which I haven't seen the ad for, but I hear about it. And currently there's no clear evidence that any supplement alone or in combination can prevent or reverse dementia. It's difficult to study these kind of alternative treatments because you need large placebo-controlled clinical trials that are done over many years. And really there's not funding. I mean, companies that make supplements and vitamins and things like that generally aren't financing clinical trials. And so, and the ads will say this product may improve memory. So they're not saying it does because they don't have the evidence. And physicians, if somebody has a vitamin deficiency, then they can fix that. But it's rare to see a reversible dementia that's due to a vitamin deficiency. Are there any specific brain games that I recommend? I don't recommend any specific ones. It's more general cognitive activity and anything that challenges you a little bit, so not too easy, and isn't so challenging that it's frustrating. So that kind of Goldilocks level of challenge. And brain activity or mental stimulation can include games, puzzles, crafts, playing an instrument, singing in a choir, learning a language, all kinds of different things. As long as it's sort of you're engaging with something new and a bit challenging. And you can combine two or more of these sort of brain health habits or brain health activities. So if you're in a book club, then you're combining cognitive activity and social activity. If you're in a walking group, you're combining physical activity and social activity. So you get kind of more bang for your buck. And so a brain scan was normal. Does this mean I don't have dementia? I see lots of people with dementia who have normal brain scans. So the brain scan shows what your brain looks like, the structure. And once in a very rare while, the report on an MRI will say that there's shrinkage of the hippocampus. And if I see that, then it's pretty likely that this is an Alzheimer's disease process that's happening. But I can count on the fingers of one hand the number of times I've seen that in a report. So it's I learned in graduate school that absence of evidence is not evidence of absence. So basically, if you can't see damage on a brain scan, it doesn't mean that it's not happening. So PET scan shows brain activity, looking at brain metabolism, and that can be helpful for differential diagnosis, but sometimes it's, again, it's normal and the person clearly has dementia. And it's not used very often because it's expensive and just difficult to get. So really, dementia is a syndrome, and it's based on how the person's functioning in daily living. But if I do see somebody who has mild cognitive impairment and they have an MRI that shows temporal lobe atrophy, and the same person has a PET scan that shows kind of an Alzheimer's pattern, then I can be reasonably, my educated guess, it can be reasonably well informed that this is probably their mild cognitive impairment is due to Alzheimer's disease and that they are likely to progress to dementia in the shorter term. The cognitive screening tests, I passed the cognitive screening test, said it was normal. Does this mean I don't have dementia? Again, I'm looking at how people do in everyday function, and the most commonly used screening test is very easy. So especially people who have a higher level of education, they often get a perfect score, even if they have significant cognitive changes happening. And there is a newer test that's more sensitive called the MOCA, Montreal Cognitive Assessment, but even that one doesn't always detect problems. So people can perform well and still have a diagnosable memory disorder. So if there are concerns, the physician or clinician can refer to a COA, but again, have to be 60 plus. And if they're younger than 60, then they can still refer, and then I'll see them on my other waiting list. So I'm going to try to breeze through some of the next things. Family history doesn't necessarily mean that you will get it. It's more concerning if one of the family members developed dementia prior to age 65, if there's multiple relatives across more than one generation, or if you happen to know that you have a gene variant associated with Alzheimer's disease or other dementia. Pretty rare that somebody's going to know that information. And family history, again, it's not a guarantee. It's only one of multiple factors that contribute to risk. And I think I'm going to skip over this one, but basically I tell people that if they're struggling with memory, that's because their brain is letting you down. It's not that you're not trying. It's kind of like if you have arthritis in your knee and you can't walk as quickly, that's just your brain isn't working as well as it should be. So oftentimes people will, they might use the word stupid, or they'll be kind of berate themselves for something that isn't their fault. And the other term I use is neurological bad luck. Some people get multiple sclerosis, some people get brain cancer, and some people get a neurodegenerative disease. So these are recommendations. If somebody is diagnosed with MCI or dementia, I recommend communicating and discussing with close friends and family. Most people will be supportive, doing what you can to have a healthy lifestyle. But even if you check all those boxes, do all of those lifestyle habits 100%, there's no guarantee that that will prevent further progression. And if you are a family member or care partner, it's important to recognize that the person's doing the best they can. They're not trying to be annoying, but they're just not able to do the same kind of functions that they used to be able to do because their brain isn't working as well. And definitely speak with your doctor if you're experiencing stress related to providing care for your family member, because there are supports available. for that. So, excuse me, and here are some recommended contacts. The Alzheimer's Society is a great resource, and they're there for anybody with cognitive changes. It doesn't have to be suspected Alzheimer's disease. So they have a bit of an image problem. And then the iGeriCare also has some resources, and that's got my phone number and my email address. So I think I've left 10 minutes for some questions. So, and if one of the questions is, could you please share a slide, then I can reshare. So I'm just going to stop share. And I'm going to switch to gallery view so I can see some people. And there are 27 people, 26, not counting Melissa and me and the computer that's recording. So I am going to.
Would you like me to read the questions out to you?
Sure, that would be great.
So our first question is functional cognitive disorder the same as mild cognitive impairment?
That's a very good question. It depends kind of who is using the term, but often the term functional cognitive disorder refers to something that's not neurological. And so it's pretty uncommon. So I have seen where somebody was kind of presenting as if they had dementia or as if they had a significant cognitive impairment, and it was kind of a psychological sort of a cry for help, and they didn't, their pattern of performance didn't make neurological sense. And that's pretty unusual though. So I'm not sure if that's the way that the term was being used, because what I'm talking about when I'm talking about functioning is I'm talking about difficulty with everyday functioning that's due to a cognitive disorder. Not sure if that makes sense.
So the next question is, thank you for your presentation. Can you speak a little bit more about meds that interfere with brain chemical and memory? You mentioned gravel.
Right. Okay. So I'm really the best person to talk to would be a physician or a pharmacist. But the types of medications that I look at are things like, especially some of the medications for anxiety, especially the benzodiazepines, so the PAM family, clonazepam, lorazepam, those kinds of things. There are some anticonvulsants that also can interfere with memory. And really it's and things for sleep. So a lot of the medications for sleep, they interfere with memory because they're kind of sedating. And the thing with some of the medications is I've had people come in and they say, well, this medication makes me feel dopey, but it's the only thing that controls my migraines. Or, I have neuropathic pain and being on this muscle relaxant makes my life tolerable or more tolerable. So it's always a balance between the risks and the benefits. And that's really, a physician type of a question, or a pharmacist.
You mentioned that not all people with dementia have Alzheimer's. What makes a person's dementia associated with Alzheimer's?
Okay, so that's a really, really good question. So the thing with actually, I think I maybe had a slide about how do we know if it's Alzheimer's disease? And the short answer is we don't know, because Alzheimer's disease is basically, it's a pathological diagnosis. And so with really, we don't do brain biopsies, so we don't know whether 100% for sure if that's what it is. But there is a clinical diagnosis of Alzheimer's disease, and typically the main issue is memory to start with. And then oftentimes there's difficulty with language, visual spatial ability. It's often a gradual change. And sometimes there'll be brain imaging that's consistent with that. And if there's change in function that's enough to call it dementia, then the term I usually use is probable dementia, or I might say it's mild stage dementia and an underlying Alzheimer's disease brain change is suspected, something like that.
Thank you. I'm just going to check. I don't think I have any additional questions. Oh, someone has their hand up.
Okay.
Linda, you could go ahead.
Hello, thank you, Colleen or Dr. Millikin, for your presentation. This is excellent information. I'm wondering if you have any strategies to offer for not dealing with, but talking to somebody that has dementia and that is very unrealistic about their abilities. So, for example, my mom is in supportive housing now. We recently had to take her from her home and put her there. And I say put her there because she didn't want to go. And she every day calls me and still wants to go home. And you know, I see her, she'll forget about it for a while. I can distract her. But it's really ongoing about wanting to go home. And she thinks she's very capable of being home and that it's ridiculous. And she's just going to get on a bus and go there. And I don't know exactly what to say. I mean, I've been doing some research, but if you have any helpful information, I would love to hear it.
Okay, yeah, that's a really hard one because, as you say, if you distract her, you know, the more busy she is, probably the less kind of focused she is on going home. And it's just not something that she's not going to recognize. She's not going to wake up one day and say, yeah, I really need to be in assisted living. You know, sadly, it would make life a lot easier. But in terms of communicating with people around challenges, kind of really just sort of validating, you know, I know this is really hard. You know, I know you're doing the best you can, and yeah, trying to distract.
Yeah,
Saying,
I mean, I'll say to her, you know, it's unsafe to go home. The doctor says it's too unsafe for you to go home, and then she forgets that. But yeah. Anyway, I don't know. Or maybe if there's a support group with other people that are going through the same thing, that I can get ideas from them, or that I could bring her. I mean, it's supportive housing, so there's lots of people there around her that are very aware of this kind of thing, but it becomes very difficult for family members for sure.
Yeah, and it's natural to kind of try to want to explain. It's just that isn't going to be retained.
It forgets the next minute and then calls me again. Yeah. It's the one thing she doesn't forget.
Your phone number.
Is that she needs to go home.
Right. Yeah.
And I have read that home is a safe place for a person with dementia because it's a memory of somewhere where they felt good about things when they're losing their memory. And so that it's not necessarily the house that they're wanting to go back to, it's their sense of well-being that they remember when they were in that place. Yeah.
No, and those kind of moves, they're always, you know, sometimes people will not want to move. And I was just talking to a couple the other day, and they are thinking about moving. And I'm saying, well, you know, it is a balance because some people move too early and they could have stayed another year or so in their home, but you know, and then sometimes people move too late and you know, they can't remember the names of their table mates, or they can't find their way to the room, or their suite. And so it's just, and it's a balance. It's not like you can kind of snap your fingers and say, okay, today I'm going to move to assisted living. It doesn't kind of work that way. And yeah, the insight isn't there. And that's because they don't remember the times that they were unsafe. So people are disappearing off my screen. So yeah, and really distraction and just acknowledging that, you know, this is hard. It's hard for you. It's hard for her. And, you know, and not, Alzheimer's Society is a great resource. There's also a woman called Teepa Snow. I'm actually just going to try to put that in the chat. Teepa Snow, and she is she's an occupational therapist, but she's an expert on communicating with people with dementia, and she's amazing. She's given presentations here, and it just, you know, and it's about, yeah, it is communication, and yeah, it's just very hard.
Thank you.
Yeah.
Do we have any other questions for Dr. Millikin? I don't got any on mine. Did you get any private questions in your chat by chance?
Let's see here. Yeah, I did get one, and it was about chronic traumatic encephalopathy, which is for multiple head injuries. And that's a tricky one, because I'm sure there's going to be a lot more kind of recognition of that. But currently, it's really the pathological diagnosis. So when I see somebody who's had multiple head injuries, that does raise concern. But it's also tricky because sometimes conditions can lead to multiple head injuries. So, for example, if, and this is really sad, but people can get brain injuries from domestic violence, and they can get PTSD from domestic violence, which PTSD is one of those things that can interfere with memory. So it is very, very tricky. And the other thing that the person mentioned was about kind of things that a family member with dementia enjoyed. And so things like music, and, you know, doing familiar activities that they were able to continue doing, you know, kind of as able. So, but yeah, I've seen animals. I saw one person with very advanced dementia and all kinds of behaviors. He was just in very bad shape, and we think he had a brain injury and a dementia process both happening. And, you know, he didn't speak English. He was in this unit with, anyway, this was when I was on residency quite a number of years ago now. And somebody brought in a little dog. And the little dog was sort of sitting the other side of the hallway. And this guy started to smile, and he started to laugh. And for those few minutes, this guy's, you know, kind of experience in the moment was so much better than it had been. I just thought, you know, can you bring that dog in like every day? So that's not a non-pharmacological intervention, right? So there's a lot more that we don't know. Okay, Trish has her hand up.
I do. You know, I've been in long-term care with my two relatives for over 9 years, so I got really familiar with what goes on there. I would highly, highly strongly suggest, please don't put dementia patients together with non-dementia patients. It just does not work, and is very unfair to those people who are already suffering from the inability to find and learn, because the environment is so foreign to them. They have no understanding as to why they're in a hospital. And we really need to make it a real home for them, because we know from Australia's experience of creating a functional, normal home next to their long-term care facility, they only needed one support person for the persons with dementia who were free to come and go there to manage, and they had no incidences, no aggression. Everybody just went and did their own thing that they remembered in their memory and in their past. Yeah. We really need to change the model of care, especially for those with cognitive impairments.
Yeah, absolutely. Absolutely. And there are models out there that are And it's, I have done some consultation, not super recently, but in long-term care around behaviors. And a lot of it is about where is this person at? What are their habits? There was one lady, she would go and unplug the fan. They would put a fan in the hallway, and she'd go and unplug it. And you talk to the family, and they said, well, she grew up on a farm. You don't waste electricity like that. And so, and the staff are saying, well, how do we get her to stop doing that? And I'm saying, well, keep her away from the fan, because this is what she's going to do. You can't go back and change her history. And she's not going to remember. You can, tell her all the time, don't go near the fan, don't unplug it. She's going to do it. So, and it's, changing expectations, changing, the environment so that people can do the things that they enjoy doing, or that's part of their life. And I'm going back to my internship, but there was a patient. This was a behavioral neurology unit, so these were people who had a lot of behaviors that were kind of putting them at risk and other people at risk. And this one lady, she was sort of coming into conflict with the staff, and talking to the family is super helpful, because we found out that this lady was a security guard, and that totally explained why she was going around trying all the doors, and if she found one open, she'd go in. So as far as the staff went, we basically started treating her like a security guard. So she'd come in, just like, oh, hi, Mrs. So-and-so, we're doing fine here. And then she'd go off. And so, it didn't make it hard for the staff, and it made it a lot better for her. So, and meeting people kind of where they're at, that, if somebody is saying, I need to go to school, I need to, I'm going to be late, kind of saying, okay, you need to go to school. So, where do you go to school? Who's your teacher? What subjects do you like? And just, kind of trying to that they're, that where they are, rather than trying to fight with that, because it's not, they're not going to see where they are now, because they're just how the brain works.
I think that's all the time that we have for today, but I want to thank you so much, Dr. Millikin, for coming. It was a very informative and interesting session. And everyone that's still left, thanks for coming and being here with us and spending your lunch with us. And we'll be sending out a survey shortly, just to kind of gather some information on other things that you might like to see, and if you want more sessions on a topic like this, or what sessions you would like. So we'll be sending something out shortly. And I'll also link some of the things that Dr. Millikin was talking about in my email. So I'll put a link to the Alzheimer's Society, and I think that occupational therapist. If you can send me that contact, I'll email it to everybody that was in the session today as well.
Okay, yeah, I'll do that right now, because I just realized that the TIFA Snow thing went to somebody.
Was it direct message? Okay,
direct
no
message.
worries.
That happens all the time. But I'll also
worries.
send. I've got the. I've got her website too, so.
Okay, great. Yeah, I'll send it out. And if there's anything else that you want me to send out, I can send it out to all the participants as well.
Could we have access to the slideshow presentation, or even the recording? Is that possible, in case I want to refer to some of it later?
Yes, of course. If you can send an email to the Family Center, once the video has been uploaded to our YouTube channel, I can send you a link with it.
Okay, thank you.
You're
Thank
welcome.
you, Dr. Millikin.
Okay.
All right, thanks everybody. Enjoy the rest of your day.